Thank you for inviting me to come and to give some maybe some information about the things that I do as a psychiatrist at the Jewish General Hospital. So basically I can maybe give a bit of background about the things that I do as a psychiatrist, the kinds of problems that I see, and then this presentation that I'll be giving is geared a little bit more to maybe a specialty crowd or audience. So I'll try to just explain as I go along, and hopefully we can have some interesting discussions and questions at the end as well. Because really, what we're talking about with cultural competency in psychiatric care is how do we adapt our regular work as medical doctors, or in my case, as a psychiatric physician, psychiatric specialist, how do we adapt what we do to our changing world, where we have so many new people coming from different parts of the world, many people speak different languages, have different cultural backgrounds, and they may not understand or see health issues or mental health problems in the same way as we do at all. So this is the real dilemma. I think it's a dilemma that we face in all kinds of fields across North America and Western Europe as we receive more and more people of different backgrounds. And this diversity is so enriching to us, and what we risk doing by not attempting to be culturally competent. I mean, competence is a bit of a strong word. I would just say maybe being culturally sensitive or culturally appropriate, or being curious about people's backgrounds, and recognizing the richness that diversity brings to all of the different fields that we work in as Canadians and people from Montreal and Quebec. So also a bit of background by way of psychiatry. I don't know if any of you are in mental health fields or not, but psychiatrists are different from psychologists. Psychologists go through training in university, and they might go through, they might do a master's degree or a PhD. They might learn different research methods or engage in different research projects. Psychiatrists can do that as well, but psychiatrists go to medical school first, and then they go through a very practical training program called a residency training. And then if they want to do research type work or learn more research methods, they might do what's called a fellowship, or go back and do a PhD and or master's and or PhD. So psychiatrists, psychologists are a little bit different in the kinds of people that they treat, the kinds of problems that they see. Psychologists might work more in the community. They might work in a business or in a school or in a hospital, university. Psychiatrists are much more likely to work in hospitals, or somewhere, maybe in even a psychiatric hospital, where individuals are suffering relatively severe and prolonged or persistent problems. That's because psychiatrists use medications often to help treat different kinds of problems, whereas psychologists may be more specialized in talking therapies or in psychometrics, we call like measuring mental or cognitive functions. Psychiatrists there's a lot of overlap, so psychologists may be parts of teams that treat people with medication, and psychiatrists may also give input into psychotherapies and psychometric problems too. So that's a bit of a background about what psychiatry and psychology is. Psychiatrists treat different kinds of mental disorders, like say depression, schizophrenia, post-traumatic stress disorder, anxiety states like panic disorder, or maybe even autism spectrum disorder or substance use problems. So it's quite a varied field. There's a lot of different issues and problems that can come to bear. But what I do as a psychiatrist principally is I'm what they call a cultural psychiatrist. It doesn't mean that I enjoy a fine night out at the theater or something, or at the opera, although maybe I do on occasion. But a cultural psychiatrist really means that I'm interested in this problem of culture and of language and religion, and how those different backgrounds, how these different contexts inform and teach people how to be depressed, or how to show distress, or how to show that they're having difficulty. So these kinds of problems are heavily influenced by our context, by our society, by our families, by our cultures of origin. So that's where cultural competency comes in. So I'll just give you a basic outline I guess, of what I'll be talking about tonight. I'll try to answer a few questions. What is cultural competency? Why cultural competency? I guess I've already kind of explained that. What is cultural consultation? How is cultural consultation culturally competent? Cultural consultation is the kind of work that I do at the Jewish General Hospital and more widely through the McGill network and throughout Montreal. Cultural consultation, which we'll talk about later in more depth, is a tool or an approach to diversity in mental health. So that's what we'll be talking about. And then I'll explain a few resources and talk a bit about what the future may hold and why these things are so important and relevant to us today. So what is cultural competency? And again, I mentioned already that competency is a bit of a strong word because for me, I don't ever feel totally competent when I'm working with people from different cultural backgrounds. I think that it's important to remain very humble when you're facing difference, just because other people know a lot more than I do about various languages and backgrounds and religious traditions. But what I can do is I can cultivate certain skills that will help me as I approach people from different backgrounds so that they'll feel comfortable talking to me, and then maybe they'll disclose very important information that otherwise would have gone hidden or neglected. That's really what cultural competency is in the end. Now, you can have very specific competence with a certain group or religious tradition. You can know an awful lot. My own religious tradition, I'm a Latter-day Saint or a Mormon, so I know a lot about that community. I know a lot about their beliefs. I know a lot about their practices, their history, but I know much less about my Muslim friends' backgrounds and what they believe and how their beliefs might influence how they feel sad or anxious. So if I'm a psychiatrist working with somebody from a Muslim background, from, say, just by chance the Middle East or North Africa, then I have to be very humble and not assume that I'm super competent to know everything about them. And I would expect the same thing from a clinician I'm going to go see. If they say, well, what are you doing that for? Or why do you fast once a month on a Sunday, or part of my religious tradition? I'd hope they'd be curious and open and accepting of my background, my beliefs and my practices. So this is really what cultural competency is. And I've written down a few things here that maybe you can read if you'd like, but I think that I'm kind of talking through most of what I want to say. Lawrence Kiermaier is a very well-known cultural psychiatrist. He works at McGill. He's really my mentor and somebody who's taught me a great deal over the last many years. This is some of his thoughts about cultural competency: the acquisition of specific knowledge, attitudes, and skills that will improve the delivery of effective, culturally appropriate, and responsive mental health services. So when you talk to anybody, especially if you're in a clinical encounter with people trying to understand how to help them, then what you see, people talk about people like an iceberg phenomenon. So you're talking to somebody, you're getting to know them just after a few minutes, you see just the tip of the iceberg. So what do you see? You see their words, their tonality, body language, and gestures, but really you're only seeing just the surface of things. And underneath the water are maybe all the important things. A lot of people who come to see psychiatrists, including me and our specialized clinic and team, are very reluctant to talk about what they think maybe Canadians or Quebecers are not going to be interested in. Many of the things that we think are maybe most important to them, specifically their beliefs, their personal practices, their private practices, and their religious practices, and their traditions that they bring with them from other countries or places. So this is part of the cultural competency, is being able to dip below the surface and encouraging people to allow you to actually do that. Because most of us have we know what is acceptable, what may not be acceptable, and we're on guard immediately. When people come in to see me in my practice, as part of a cultural consultation, I know that I'm being judged. I'm on trial immediately. Who is this person? can he be trusted? He looks like a white guy, sort of European background, English speaking. All these things come up right away, right? So this is what we're negotiating and trying to understand better. So I spend a lot of time actually just putting people at ease if it's possible to do that. So I might explain to people what I'm doing, who the members of our team are, what people say is confidential. I need their authorization to speak to other people like lawyers or government agencies or Immigration Canada or whatever. And so when people learn, people may not trust that, but hopefully by the end of our initial evaluations anyway, people will start to see that I really am somebody that's there for them. This is part of cultural competency as well, but also part of cultural safety and humility, which we'll talk about a bit later. So just to get a little bit technical, there are some elements of cultural competence that I can talk about. Cultural competency is another way of saying it. So you can look at organizational factors, like how does an institution set itself up to be welcoming to other people? For example, if you walk into a hospital, you might see signs in French and English, but do you see signs in Tamil or in Arabic or in Spanish? And these are languages that are on the move in Montreal, languages that are being spoken more and more often. So it's not very culturally competent of an institution like a hospital not to think about having signage in languages where there are a lot of people living in their area who are using that hospital. Just an example of a very simple thing for organizational level cultural competency. And then there are lots of individual level skills. This is just kind of fancy jargon. Scientific mindedness is just an example I can tell you. It refers to how open-minded a person is and how reluctant a person is to form conclusions too early. So one of the death knells or serious problems if you're doing a cross-cultural evaluation is making premature conclusions about what a person believes or thinks or what's driving his or her behaviors. So this is something that some people are better at doing this than others, probably from the beginning, but you can practice doing this and refrain from making too early conclusions about people. There's lots of other things we could talk about, but you can leave it at that. There's also another idea put forward by a colleague of mine, Rob Whitley at the Douglas Hospital, who talks about religious competence. So this is where not just cultural issues, but religious factors as well become important. And you can actually harness religious beliefs and networks and religious connections that a person may have to their great benefit, if that's important to them. Many people aren't religious, and so you wouldn't dwell on those topics in the same way. But a lot of new arrivals to Canada, immigrants and refugees, are really religion is very important to them, and it fits into their worldview and plays an essential part of it. So we again have to work hard to provide a safe place for people where they can really feel comfortable, and maybe if we're lucky, they'll start to tell us some of the things that matter to them, not just the side effects of their medication or if they got their blood test taken or these kinds of things. So a related concept is cultural humility. I mentioned this already a little bit, but I'll just explain, or I can read this little quotation here. A lifelong commitment to self-evaluation and self-critique, to redressing the power imbalances in the patient-physician dynamic, and to developing mutually beneficial and non-paternalistic clinical and advocacy partnerships with communities on behalf of individuals and defined populations. So the important part of this is that there are power imbalances between a physician and the patients and their families, or their clients and their families. So cultural humility, the idea behind it is that a physician will try to redress or improve those imbalances. So bring the physician down a little bit and elevate the client and their family to a position of more power. And this is very difficult to do, especially when people have no power. So if you're working with a refugee family who's new to Canada, they feel like they may not have many options, or they may not understand our system in Canada very well, or they may feel constantly on the margins of society, they're trying to gain access and status in Canada, and they don't know what's going to happen to them next. So it's hard to elevate people in those positions to a place of relative power. But the degree that a clinician can do that is a sign of success, especially in this kind of work. Cultural safety is another related concept that we strive to practice in cultural psychiatry, to be culturally competent as possible. These are general skills that are not talking about knowing a lot about a specific culture or religious identity or religious practice. So cultural safety is acknowledging the power imbalances inherent to clinician-client relationships and in the structural violence and inequality in the greater society. The clinical encounter can become safe by discussing these historical and social issues. So a group that would be especially affected by cultural safety might be Indigenous communities who suffered many centuries of oppression and many centuries of genocide. Sometimes, often, we harm other people without even knowing we're harming them. So we may not acknowledge, for example, how much we owe to the Indigenous communities and how much they laid the foundation in many ways for what we call Canada today. So how can we address this in clinical practice? We can try to bring these historical ideas and these historical wrongs into the discussion and acknowledge them, and therefore we can create a safe environment. And this also would apply to Indigenous peoples in other countries, like the Maori in New Zealand, for example, or other places. Now this is maybe the busiest slide, so I'm sorry, it's hard to read, it's kind of small, but I wanted to let you know that there are cross-cultural tools that we can use, and this is kind of where I'm going to jump into what I do in my regular practice for the next few minutes. So cross-cultural tools, we've talked about cultural competency, and that's the one in the middle. I can use the mouse, he was telling me. There we go. So in the middle here, cultural competency. And we can compare cultural competency as an approach or as an ideal to some of the other tools that have been developed. One of them on the left is called the Cultural Formulation Interview, and this is the most recent attempt to bring culture and issues of culture and cultural competency into the routine clinical practice of psychiatrists and mental health professionals. So it's basically a 16-item questionnaire that covers various points that were originally in this little box. Oh, here we go. In this box here, you can see the DSM-4 TR cultural formulation. The cultural formulation identified some key aspects of culture that we need to talk about. For example, a person's cultural identity. What do they call themselves? What kinds of ideas make up who they are, for example. Another key idea in the cultural formulation would be how people explain distress or how they explain illness. So that's like the causation. What explanatory models do they use to explain what they're going through? Another key element from the cultural formulation, we may go over this later, I can't remember if I have a slide on this, but another key element of the cultural formulation would be how does a person function in cultural context, and is what they're doing acceptable or not in their cultural context? So if a woman's staying at home all day and not leaving very often and doesn't even leave the kitchen very often, you might wonder, well, maybe that woman's depressed. In some societies, it's acceptable, maybe even normal, for a woman to not leave the home very often for reasons of modesty. So a woman may be expected to stay at home more often. So it would be inappropriate for me to just say, oh, she must be mentally ill, depressed, or maybe abused by her husband or by her society. These are things that would be important to put into proper context. So this is one of the things that the cultural formulation asks us to do, and also to look at the stressors that are maybe culturally related that are causing problems. For example, having a refugee claim that has not yet been resolved is a horrible stressor for anybody who's had to endure that. And sometimes if somebody's going through a refugee claim and it's uncertain and they're sure they're going to be killed or harmed if they return to the country of origin where they came from, and it's looking grim they might be deported, medications are not going to be very helpful, okay, to help that person through their problems. So what needs to happen is they need to have a resolution to the whole immigration refugee dilemma. That's what they need to do. So this is where the cultural formulation is helpful. So, sorry, this is a long way to talk about this. So cultural formulation informs the cultural formulation interview, which expands it to include 16 questions that clinicians can ask kind of hopefully in a relatively short time, maybe in a half an hour or less, once they get skilled at using it. In practice, really, though, once you start asking about cultural questions to people, it often gets a lot more complicated. So this is one of the problems in using these cultural tools in routine healthcare, is that it often takes more time than people have. So this is one of the tensions we'll be talking about, how to work this out. Now, what I do is we don't use cultural formulation interview so often. I don't call myself culturally competent. This is more sort of an idea that might come from the United States, where there are specific skills that maybe universities or medical organizations put forward for residents or trainees to learn to be, and they can call themselves culturally competent in a certain area or field. What we do here in Montreal is called cultural consultation. Now, I'm going to go over this later for you, but essentially the cultural consultation service is what I direct at the Jewish General Hospital. It was founded in 1999 by 3 senior colleagues, Lawrence Kiermaier, Cecile Rousseau, Jaswant Guzder. And at the time, I was a resident just finishing my training. So I happened to just kind of come in right onto the scene at the time of this new development. This new tool was being created and used. So I ended up being the director of the service. And it was founded because of the changing immigration to the Côte des Neiges area in Montreal. So whereas before in former decades, most of the immigrants to the Côte des Neiges area may have been Jewish or from Eastern Europe or other European backgrounds, since the 1970s, 80s, it's totally changed. So most immigrants now come from Asian countries, maybe from the Caribbean, maybe from the Philippines, maybe from West Africa, or the Middle East. So because of this change, there was a need for some way to approach people as they came to the hospital with mental health concerns. So I'll talk more about cultural consultation later. That's just to give you an idea just of the kinds of tools that are available and are being developed for working with diversity. Now, why cultural competency? Why do we even need this? We've talked about it already, the changing immigration and patterns around the world, and you know that now it's helpful to know several languages. And I was mentioning earlier, I'm trying to learn Mandarin myself, and it reminds me what it may be like. What if I, for example, immigrated or applied for refugee status in China? You know, what would I be like? How would they accept me there as a doctor, as a psychiatrist? Could I communicate with anybody? No, basically. I'd struggle. I'd be reduced to the level of a child in my language skills. And I wouldn't know the system. And I'd make all kinds of mistakes. And I'd hope that people would be patient and kind and try to help me through. So refugees, we live in a time of refugee crisis, especially in Western Europe and Southern Europe, and also in the United States, where there's constant discussions what to do with the refugees that are coming, what to do with people who are living illegally in various countries. When I went to Europe in 2015, it was at the height of a huge influx in refugees to Western Europe from North Africa and other parts of the world. And going from Calais, which is in northern France, to London on the Channel train, it had become kind of like a military camp, because there were so many people that had been stopped there, and they couldn't get into the UK, and they didn't have anywhere else to go, so they kind of set up a city, a little tent city there. It was really stressful to even watch, let alone be a part of. So refugees may come by sea, by land, more the case in the United States, from Mexico and Central America, at great human cost and suffering. We talk a lot about the Syrian refugees as well. So many of these pictures come from Syrian refugee. And more recently, the Rohingya, or Rohingya, maybe, different ways of saying it, from Burma, Myanmar, fleeing into Bangladesh. There are many global ethnic diasporas, over 100 recognized global ethnic diasporas around the world. For example, the African, Jewish, Arab, Persian, German, Haitian, Chinese diasporas. These involve hundreds of millions of people. So really changing the demographic contours of the world. As many as 45 million people, this is back in 2012, were forcibly displaced worldwide as a result of persecution, conflict, generalized violence. About 1/3 of these would fall under the UNHCR mandate. Most refugees are internally displaced people. So that means they just move to somewhere different in their own country, like in Syria or Afghanistan or so on. Just a case in point of a modern diaspora, the Ahmadiyya, a group of people. I'll just read a bit about them if you don't know about them already. They represent a latter-day revival of the religion of Islam. In Pakistan, the Ahmadis have been officially declared to be non-Muslims and are the victims of violent attacks. In Bangladesh as well, poorly treated, and in Indonesia as well, some groups want to ban the religion altogether. So in this process, a new global diaspora is born. Ahmadiyya communities are now in more than 200 countries. 25,000 have come to Canada. So this is just one of dozens of groups that you could talk about. And historically, there are many, many, many more. In fact, many people here today are probably the result of various diasporas. So, where do refugees go, and where do newcomers go among the wealthy nations of the world? Australia has a relatively high proportion of foreign-born. It may rise to 32% of the population by 2050. So that's interesting. Among the G8 countries, Canada has the highest proportion foreign-born. I don't know if you knew that. And so in Canada, the proportion foreign-born hovers around 20%, and it has for a very long time, many decades. Japan, on the other hand, has 1% of its population foreign-born. But this is nothing compared to some countries. One of the residents I work with is from Oman, and she was telling me that in Oman, there are a few million Omanis and a few million other people that are working there. So it approaches 50% of the population in Oman. But what about the United Arab Emirates? 83.7% of the population is foreign-born. It may be the highest in the world. Over the years, Canada has accepted about 200,000 refugees and asylum seekers. The country that accepts the most refugees and asylum seekers, I'm talking about people that come through the UNHCR, the United Nations, the country that accepts the most is the United States. Now, not all countries handle newcomers so well, and we think maybe of Turkey, or maybe of Lebanon, or maybe other countries who are receiving millions of refugees. We think maybe they're having problems with their refugees. But what about Australia? Well, what do you say, what about Canada? What about Australia? Australia, unfortunately, in 2001 began to rent facilities on islands near to Papua New Guinea. And they began to use these offshore islands to warehouse refugees. One of these sites, it's Nauru and Manus Islands. Manus may be closed down, and Australia is talking about making a deal with the United States, so some of the people there can go to the United States to live. But it's not really clear. I couldn't find much information since October 31st, when it was supposed to be closed down. But here's where the islands are. And at the end of the presentation, I'll show you some pictures of people who are marooned in these refugee camps, essentially concentration camps. Now, there is great diversity in Montreal as well. Did you know that Arabic is the third language of Montreal now, since the 2011 census? It used to be Italian for a long time. But even Spanish beats out Italian narrowly, and will probably beat it out even more, because more and more Spanish people are coming from Latin America. Now, in the Cultural Consultation Service a few years ago, I went through just the first 12 consultations of the year. And this is where the people came from. They came from, every single one came from a different place. Western Sahara, Afghanistan, Peru, and so forth. Tremendous diversity. So very, it's a great opportunity to practice principles of cultural competency. Just to give you an idea of some pictures of where people come from. These first 12 consultations in 2013. So you can see that in trying to give appropriate, culturally sensitive and competent care is going to be a real challenge. People come from vastly different backgrounds, even from Little Italy in Montreal. Haiti, Mexico, the Caribbean, China, Chad, DRC. Now, we do receive refugee claims, people who are making refugee claims from surprising places on occasion, like maybe from China or Japan or United States. And you might think, well, how could that be? Like, why would people be making refugee claims from places like that? And essentially, people run afoul of the government everywhere, and they may feel that they're being persecuted, and they may really be in some cases. So they may make a genuine refugee claim to Canada to see if Canada can give them asylum. Now, what is cultural consultation? I've talked about this a lot. And in cultural consultations, this is kind of how I feel. You can see me there a little bit stunned. And other people are doing all the talking. I'm trying to follow. I'm trying to see how I can help. How can I be of assistance? How can I not be offensive? How can I open the discussion rather than close it down? This is really the position that I'm in. So we went through most of this already. Cultural consultation, as I say, essentially family doctors, other doctors, social workers, psychologists, sometimes educators, sometimes lawyers. These kinds of helpers in the community will approach us. They'll say, we have a difficult situation at a school, or a difficult situation at a hospital, or in my practice, or at the university, or wherever. And they'll make a referral. And oftentimes they're interested to know what the diagnosis might be. They're kind of confused about the diagnosis. They may also want us to help them to, there might be a very thorny immigration problem. Like, for example, somebody may have come to Canada, they may have obtained permanent resident status, and then maybe because of some mistake or poor judgment, or maybe due to a mental disorder, they may break the law in some way. And if you break the law, you can have your status revoked. And it happens sometimes to people, and it happens sometimes for unjust reasons. So this is mainly where we'll be consulted to try to help with thorny immigration problems. We'll try to portray a cultural, we'll give a cultural background and explain how this affects a person's behavior, and maybe also highlight that there might be a mental illness too. So the aim of cultural consultation really is to complement standard psychiatric evaluation by focusing on social and cultural dimensions that may be less familiar and that tend to get less attention in routine care. This is that cultural formulation I was telling you about. This is what we use. These are these points I was talking about: cultural identity, cultural explanations of the illness, and then factors that may that are associated with stress levels or functioning. This fourth point down at the bottom, I didn't talk to you about. See if I can get this mouse over here, the arrow over here. This one here is a very important one I touched on a little bit. It's cultural elements of the clinician-patient relationship. So that's when I ask myself, a person comes into my office, and I ask, what is the person thinking of me? What do they think I represent? Usually I represent the status quo, the oppressor, institutions of society like the police maybe, or healthcare, or the government, or maybe they think that I'm there to try to question them and tell their lawyer the truth and so on. So we have to be very careful as we're working with people, try to see how they're going to be reacting to me, and then I can start to maybe be of assistance to them. So cultural consultation is a person-centered approach. So that means we really care about the individual person, and we try to hear what the person's bringing to the encounter, as I say. But even who a person is, how you define yourself as a person, is mediated by cultural factors. So in North America, Canada, maybe in the UK and France, other places like that, people have often talked about personhood being defined as egocentric. Egocentric doesn't mean you're selfish. It means that you tend to count yourself first, okay, a little bit. So when somebody asks you to tell about yourself, you might say, well, I'm a doctor, I work at Jewish General, I'm married, so you might talk like that, you know? And so you're more interested maybe in your own accomplishments. Not that that's a wrong thing, it's just how we're kind of conditioned to be and behave. But in other parts of the world, people may have a very different approach. There's a thing called a sociocentric approach to personhood. So when a person from another country or another society may be asked to talk about themselves, they may say, well, my family grew up in this city and my grandparents were living there, or I've had ancestors there for this long, and my last name is this, and that means I'm connected to this group, and so on. So it's less about your own accomplishments maybe, although that could be important, and maybe a lot about your family and where you come from. Now there's even more interesting, or I shouldn't say interesting, more ways to define yourself as a person than egocentrism, sociocentrism. Professor Kiermaier, McGill again, has talked about ecocentrism, where you might define yourself as a person like some indigenous peoples might do by where you live on the land, or what the land means to you and to your family and to the world around you. So an ecocentric approach. Not even so much about your family or about what your accomplishments, but about what the land means to you and how it affects your life and sense of who you are. And finally, the last one, cosmocentric. This is maybe lesser known, but some groups or some belief systems may put great importance onto ancestors and ancestor worship, and how the ancestors or how spiritual forces might influence the here and now and lived experience of today. So if that's the case and you're interviewing somebody with a cosmocentric approach to how they are as a person, it's important to recognize that and try to be open to hearing what they mean and what's important to them. Now, of these 12 people who came in back a few years ago that I mentioned already, they all had different complaints. I'll just read you a few of them. I want people to believe me, Western Sahara. I need medication, someone from Afghanistan. Do the doctors think I'm crazy? Or a Peruvian client. I started feeling depressed in Iran, from Iran. I avoid the color green, someone from El Salvador. What I feel inside my body is difficult, Montreal, Little Italy. I get headaches, from Haiti. What happened in my past affects me today, our Mexican client. A long time ago, the doctors caused my problems, someone from St. Vincent. I want my diagnosis changed, someone from China. This is like being in prison, our Chadian client. My problems are due to my refugee claim, our client from the Democratic Republic of Congo. So there are so many different opening lines that come to your attention. How do you make sense of all these things? what the Cultural Consultation Service does, we have an intake coordinator. She's been there for 20 years and is very experienced. She listens to the clinicians and asks different questions and gets background information on each individual. Then I meet with her, and we do a triage. We see what kinds of cases are coming up, who would be best to see them, and so on. Some people, their problems can be helped just by talking to the clinician. Maybe someone needs an interpreter for a different language. We have access to interpreters. We can turn away some consultations just by giving people information about interpreters, language interpreters. If the person comes to see us, we might do 1 to 3 evaluative sessions, and they're about 2 hours each. We'll give some preliminary recommendations, and then we'll end up by inviting the clinical team to come meet with us, and we'll talk about the entire case with them at what we call a clinical case conference, and it's there that we make our final recommendations. So we really work with the teams that are out in the community. They come and meet with us, and we talk to them and get their input all along the way. We also invite them to all of the cultural consultations. So what do we do differently than other psychiatric clinics or other psychiatric practices? We routinely use professional language interpreters. Not just linguistic interpreters, we use culture brokers, as we call them. So we might use people from a certain background who have expert knowledge of a group or a religion or a historical period of time, and we'll have them come meet with us, with the client, and they'll give us. They have a bridging function, so they bridge the psychiatric world, the psychiatric language. They bridge to the language and understanding of the client. So culture brokers are very important for us. And oftentimes the language interpreter will be translating in the meeting, and the culture broker will be very quiet. Because the culture broker is trying to just observe, trying to see what the person, how similar, do they know and understand that person? Or do they are they from a different kind of background? Sometimes we mismatch people, which can be very embarrassing and difficult. On one occasion, we had a person that came to us from Lebanon, and we assumed that the person was of Muslim religion, and so we invited a Muslim culture broker to come talk to us, and it turned out that it was a Christian from Lebanon. And it became very tense and awkward right off the bat. So we had to reconfigure things and bring in a different person for the next visit. So it can be very sensitive and delicate. Some people don't want interpreters present. They're nervous about confidentiality. So if some communities are very small, there aren't that many people from a certain place, they may think, well, I can't have an interpreter here. They're going to talk to so-and-so, and then everyone's going to know in like 5 minutes. So sometimes we can't use interpreters, but most of the time I have to say when our patients come in and we have an interpreter present, they are so relieved because they've never been able to tell their story to a professional in that way before, and now they can just speak from the heart. They're not struggling in English or French. They can speak whatever it is that is their mother tongue. Such a relief. Some people even weep with gratitude, believe it or not. We focus on education and empowering of the referring clinicians. So we want the people that refer to us to be able to do this on their own. So we're training them really to work with diversity all through the process. We're open to non-psychiatric explanations of illness and interventions. So if people come to us and say, well, we've tried traditional healers like a marabout, or we've tried an exorcism or a religious intervention, that's very important to us. So we want to hear all about it. And we want to know if there's people like that in Montreal that they may be able to get help from. And we'll even work with them. We'll invite religious leaders to our consultations, and we're happy to hear what they have to say. And sometimes we need a religious leader who may have very in-depth understanding of certain kinds of problems. They'll come and help us. We're very grateful when that can happen. Unfortunately, oftentimes it's not really possible. So for some reason, people may feel like religion and psychiatry are just separate things, and they don't want to have their religious leader come to the consultation. They feel like it would trespass some kind of a relationship. But we try to be open to that. We work with families all the time, if there are families available. We work with lawyers, and there's often lawyers involved for immigration. As I mentioned, religious leaders or other members of the community. We help the patient and her family feel as comfortable as possible during the evaluation. I look at them as guests in my home in a way, which is a different way to go. We spend 2 hours per session, so it's a lot different than a standard evaluation. So how are we culturally competent? I'll just run over this with you fast, and we're coming down to the end. Culture consultation, we hope, facilitates communication. We hope it improves understanding, especially on a cultural dimension. It often refines diagnosis. I won't go through all the rest of the slides on these things, but a lot of people, for immigrants and refugees, it's common to misdiagnose certain things. So a person might be, certain groups may be more likely to be diagnosed with psychosis or schizophrenia, say. Part of it might be a language barrier or language difference or just different ways of behaving and acting. So we often take a person with that diagnosis and quite commonly we'll find something else, like maybe post-traumatic stress disorder or maybe depression. And it's of tremendous importance, not just for reasons of treatment. Treatments are different, but also for reasons of stigma as well. So we recommend culturally appropriate treatment, including religious interventions if that's going to be helpful. So it's very common for us to just today I saw a woman who was having a lot of difficulties, and the person that she found that was the most helpful was her priest at a local church. And unfortunately the priest had been reassigned somewhere else. So we spent most of the meeting talking about where could she find somebody else like that could hear her out and listen to her on the terms that she thought were important. Because mental health language wasn't really the way she understood her problems very much. I still made recommendations to her doctor for medication changes, but when talking to her, we spent a lot of time on her religious connections. So really an important thing. We strive to enable the referring clinicians, as I mentioned, so they can continue this on, because there's no way we can see everybody, right? So doctors today, psychiatrists, psychologists, you just are going to see a lot of different people. It's how the world is now. So the more that they can learn these strategies, the better they'll be. And then we notice that gradually people stop referring after a while. They become more confident. And we train future professionals. We have a lot of students from all different places, often from Europe or other parts of the world too, that come because it's just an unusual approach. So people are interested and curious to see how it works. So I had some slides just looking at these different things I just told you about, so I don't need to kind of belabor all this. We often talk about, when you're looking at especially refugees, but even just regular immigrants who have come for economic reasons, we look at pre-migration factors, the migration experience itself, which is often highly traumatic, for refugees I mean. And then we look at the post-migration factors, and we kind of think often as Quebecers or Canadians, oh, people have come to Canada, they finally made it to a safe place, but a lot of people really have a hard time in Canada. And Canada is not super nice to a lot of people either. So I'll show you, well later I'll show you a couple of pictures about this, but we have a lot of learning to do ourselves. We really have to disabuse ourselves of the notion that we have all the knowledge, we're kind of high on the level of knowledge and competency, and that we are super generous all the time to people. Canada does do a lot of good things around the world, and we do admit a lot of people in need, it's true, but we have a lot of work to do as well for various reasons. I talked about diagnosis already. So just a couple of, for example, referring clinicians might say, can I take part in more of these interviews? Or we had no idea that this mother had lived through all that. this kind of thing. And so what happens is sometimes when a language interpreter is talking and someone's telling an agonizing story of leaving a country where they were under persecution and they endured all kinds of abuses, sometimes the interpreter is quite traumatized by what they're hearing. So sometimes they even stop the interview and they start telling their own stories, So we have to kind of provide a place where that can happen. And we listen carefully to that, because when an interpreter does that, they're actually providing us with a lot of important information. They may be adding in, it may not be exactly what our client or patient's been living through, but we can learn a lot sort of by analogy. And sometimes the interpreter will feel more empowered, and they'll say more of what happened. And then the patient will feel emboldened, and they can go back and tell more of the story. So it's really quite a remarkable process to see. It's very difficult to film. Like ideally it'd be to film some of these interviews and show them, but people in these circumstances are very, very suspicious, and they don't trust for good reasons. I mean, they've been abused for a long time, some people, and other times they've come to Canada and they don't feel anybody's really paid attention to them, so they're not sure what our intentions are, Okay, so I already talked about training future professionals. Let me just talk to you about some resources in case you're interested. This website, this is a listserv. You can join this listserv if you want. And I'm going to give you, do I say Antonella? Yeah, I do. Antonella. Antonella is our intake coordinator at the Cultural Consultation Service. You can call her, you can ask her for resources if you need, if you're a professional yourself, or if you want to get added on to this TC Psych list. It's a list for people there's hundreds of people in the list around the world, and people type in questions. Anybody know about a questionnaire in Tamil or Chinese Mandarin or whatever? And then people will write in and they'll say, yes, I found one here, and so on. It's a way to share information and gather resources. There's also the Multicultural Mental Health Resource Center, the MMHRC, and you can go to this link here. This is founded by Lawrence Kiermaier, again, my colleague at McGill. Go to this site, and you can get all kinds of resources online for mental health, having to do with mental health care, mental health issues. You can get questionnaires in various languages. You can click on clinical tools, for example. I think right here, this isn't live, but if you click on it, it'll come down, it'll have languages. Click on languages and you can there's all kinds of resources in different languages. Very, very helpful. We have a summer program every year at McGill at the Jewish General Hospital in social and cultural psychiatry, where you can take courses and also participate in a conference in June, usually on a very specific topic. There's also another series of conferences or series of courses on Indigenous mental health. Here's our cultural consultation service. It's online page. It's how it looks online. And here again is the number for Antonella. So, just to end off, we're pretty well on our time's up. What does the future hold? I mean, honestly, I believe the world will become more ethnically and religiously mixed. I believe that's a trend that we can't turn back. People will say that they can, but I don't believe them. There will be an increasing need to provide culturally competent diagnosis and treatment. Cultural consultation, the thing that we practice, is one way to provide culturally competent services to a rapidly changing world. And I believe the alternative is simply unacceptable. Cultural competency and culturally competent psychiatric clinical care is available to avoid tragedies like this. These are some pictures from the Australian detention centers on those islands, Manus and Nauru. Sometimes people fly over to see what's going on, and they'll just wave, help, I need to be free, help, here I am. They're stranded there. Avoid this. Avoid walls like in Palestine, in Israel, the Mexican wall, and our very own Centre de Prévention to prevent immigration to Quebec, the holding detention center in Laval. I believe these are failures, and we have to get to this point, really. These are not healthy institutions, and they're not there. They don't help people. They're there, really, they represent our fears of certain kinds of people. And most people that go there are just unfortunately placed there for misunderstandings. Okay. Thank you.
Your presentation dealt a lot with verbal communications. To what degree does your team consider, look at, and be competent in nonverbal communications?
Mm-hmm. It's a good question, and it comes up very often. For example, the classic case that happened to me was a woman that came to see us, and she would never look at me, okay? So I thought, it was when I had first begun doing this kind of work, and I thought, wow, she's really struggling, there's some problem, maybe like autism spectrum disorder, maybe severe depression. I wasn't sure. And so I had a culture broker come to talk about the situation. We met with her again, and he said, oh, she's so polite and so appropriate, look she's so reverential to you, and you're such an authority in her eyes, and she's treating you with such respect. So, whoa, I just was so surprised. So nonverbal communication often says a lot, and at the very beginning, you're always struck by what you see, and it's kind of like the 30-second me or whatever, or 5-second me. People come in and they look a certain way and act a certain way. And this is why I say I'm always very conscious of what I'm doing, because I'm on trial for all these people that I see, and they're kind of looking to see what I find is important. How do I approach them, and all these different nonverbal cues. So thank you. It's really critical.
Yes, thank you again. It's a fascinating approach to psychiatry. I'm wondering, if you have children as clients, and how are they referred to you?
Yeah. So what we do is we see people who are maybe late teens, would be the youngest, and we see people up. There's no age limit, so we've seen people who are very, very elderly. But if there are real children who are less than maybe 16, then we do have a youth or a child cultural psychiatry service, which is part of the cultural consultation service. So we have, right now, two are temporarily away. We have one person right now who would see children. So if there is a child or family problem, we can certainly arrange to have them seen.
In terms of the government, when the government decides, let's say, to admit, 200,000 or 50,000 Syrian refugees, or recently the people coming in from the United States, a lot of them think their immigrant status is going to be, I don't know, I think that some of them there will be. My question is, what sort of preparation or consultation is done, or the government just decides to do it and then just warehouse the people? It seems to be a huge disconnect between admitting the people and then what happens, in terms of integration? And is there are you involved with the federal or provincial government, and are there other hospitals or resources that the government can call on, or they don't bother calling on anybody? They just admit the people and hope for the best. I'm sorry, it's a tough question.
No, it's a good one, though. For a while, people from Haiti were being warehoused in the Olympic Stadium. That was just kind of what was happening. Kind of a large number of people came. We were taken by surprise a little bit. And we thought that the Syrian refugee crisis would be a crisis. It ended up being not so much. It ended up being that the Syrian community in Montreal took those people in and worked with them very well. So we offered our services in that instance, and only were used a couple of times. So you have to remember that we're mental health, psychiatric mental health, so it's a relatively small number of people that would come to see us anyway. But for people like you, so to answer your general question, there are resources in Montreal, and one of them that we work with a lot is called PRIDA. PRIDA is the Regional Refugee Center in Montreal, and they were near the Jewish General Hospital till last year. Now they've moved out to the east near Saint-Denis. And so when refugees make an official claim, they usually, not all the time, but usually go through PRIDA. And PRIDA has social workers and legal advice and designated representatives who can help people who need to go through that process. And then PRIDA knows about us, so a lot of our referrals may come from PRIDA. And then there's also CEDAR, which is a group of family physicians at CLSC Côte-des-Neiges, who also have expertise in refugee and immigrant problems. So if there are physical health issues, then a lot of those family doctors will help out. So there is a system in place, but we see people that are suffering from mental distress quite a bit. And then once they're stable, once they've been accepted to Canada, PRIDA pulls away, all the resources pull away, and there's really not a lot that's formally available. So that's a very difficult moment. Once you've been accepted and you kind of are left more to yourself. So we try to prolong some of the involvement of PRIDA with some of our clients. Like today, again, it was just a person we happened to see, and PRIDA, the person had gained acceptance to Canada, but was so distressed by what had happened before coming to Canada that there was no way we could just leave her, So we said, really honestly, I know you have your policies and everything, what you're supposed to do, but in this case, please continue being involved. And so they said, okay, we'll kind of stretch it out for a few more months. So this is kind of, where we're at. And there's language classes. There are various things people can do, and we often recommend language classes. Work permits. We help them get work permits, and once they've been accepted, or once they're an official refugee applicant, they can have work permits. And then that's very important to a lot of people, is to have a job, some kind of a job, or a possibility to have a job. So, but yeah, it's really, it can be very rough, very rough.
Dr. Jarvis, does your department treat these clients as part of a research project, such that you're going to have addendums to the DSM? And after you finish with a client, is there a follow-up? Does your department follow up to make sure that they're stable, and or do you turn them back over to another group?
That's a good question. So Cultural Consultation Service does not follow patients. So we tell everyone who refers to us we don't follow. What we'll do is we'll see them usually 2 or 3 times, sometimes longer. In very, very difficult circumstances, maybe and we also might see them again, like in a year's time, if someone hasn't gotten better. Today, again, I keep referring to the case today, but we saw her twice last year, and then she got accepted to Canada. And sometimes people do a lot better when they're accepted. But in her case, unfortunately, she actually became worse. So this is why we got reconsulted again. So that's what we do. We don't follow, but we make sure that the person has a place to go. And that's one of the major things we do, is we can arrange follow-up or language-specific services, that kind of thing. And as far as research, there are research projects going on, but the Cultural Consultation Service has been an official research project for about since 1999. So all the people that come there, their files will go into the database, and it's used for different reasons, different kinds of projects, like learning maybe how women refugees are treated, or what kind of coercive acts people endure after they come to Canada, these kinds of questions. So they can actually give back to the community and increase people's understanding. So,
I would like to know, how often do you actually reconsider their diagnosis? I mean, I feel like psychiatrists, sometimes they have a lot of authority, and they are confident in their own diagnosis. And in other cases, they've been following that same diagnosis for 2-3 years. Yeah. And what is the circumstances that they're going to be willing to refer their clients to you guys for 2-3 sessions, and when in 2-3 sessions you're trying to tell them there are more information? How does that work?
Yeah, that's a good question. So one of the research projects was looking at diagnosis and diagnostic change in people that were referred in with a diagnosis, and then what happened after the CCS did their evaluation. So in that paper, it's 2012 paper, I can send it to you, we found that about 50% of the psychosis diagnoses at intake were changed to something else. So it's quite a lot. It's quite a large number. Now, not everybody referring in is a psychiatrist. I mean, a lot of people are other clinicians. So that, and you know, we counted psychosis if they had a question mark, schizophrenia, or that kind of thing. They were thinking it was psychosis. So, but it's quite common that these kinds of diagnoses may change. And the reasons often are because people who have been through very traumatic experiences, there's a problem that they often suffer called dissociation. So dissociation, I think you know about this as a psychologist, but just for everybody else, it means that you lose track sometimes of time and space and where you are, and you might have very, very scary experiences. So that can often be misinterpreted as psychosis or schizophrenia, when in fact it's PTSD. And if it is a PTSD reaction, that's really important to know, rather than calling somebody schizophrenic. If it is schizophrenia, it's also important to know. So we sometimes confirm diagnoses too. So it's an interesting question.
Actually, you know, your description of what a interpreter does and how at times they get so involved in the patient's problem that they start describing their own problems.
Mm-hmm.
You know,
Sometimes.
Sometimes. But when I put myself in a patient, and I would feel really good if there was an interpreter, because interpreter, you know, is in effect is affirming. He's giving an affirmation of my problem. Because our relationship with all specialists, your specialists, are basically adversarial, in the sense that he's going to tell me something bad.
Right.
You know.
Or I may disagree or something.
Exactly.
Or force something.
Exactly. And you know, he's going to tell me something bad that I probably would not like. You know, so there is this fear all the time of going to any specialist, not only you, but anybody, any specialist. This interpreter acts as a, how shall I say, a softening phenomenon. And I was wondering if you had thought of not only making interpreter as something good to have, but in fact necessary to have. And we talked about the languages. I mean, there are, you know, 500 languages. You can possibly have an interpreter for every language.
Right.
So has McGill thought of setting up a network so that these interpreters would be available through Skype or something? And, you know, no matter what language they speak, there's a network, you click on it, and you say, okay, this guy, you know, he speaks, and listen, in Toronto, there's 10 times more people speaking different languages than in Montreal. So somebody speaking, you know, Burmese language, you know, Myanmar language. There's probably nobody in Montreal, you know. But in Toronto, there's 3 guys.
Right.
So you click, and instantly one of them is available, and lo and behold, and I would not like to see this on a little computer screen. You know, that's not real. I want to see him on a big screen with the size of the image, the same as a person. It is almost like the person is right there.
Right.
And that would do wonders to your own treatment of the patient, because you have somebody to help the procedure, you know, and break down the barriers that patient puts up because of basic adversarial condition.
Yeah. Well, you're saying many excellent things, and sometimes, like in the waiting area, I often just look and see what's going on in the waiting room before I meet the clients, you know, for the cultural consultations, and I see how the interpreter is interacting, and not all the time, but sometimes they're having a great conversation, you know, they're talking together, and I can see that what you're saying is happening. The language interpreter is really assuming a healing role with that person and supporting them through the evaluation.
I think your treatment would be much more successful.
It's better, yeah.
If there was somebody like this, you know, through Skype, fine.
Yeah.
But if someone sees a big image, a smiling person who speaks the same language that I do, well, I speak English, French, Spanish, you know. So.
Well, the thing is, like, you're right. In many cases, that's true. In some cases, people are not happy with an interpreter. I know it seems kind of strange, but one case I remember in particular We worked very hard to get an interpreter for a language that wasn't so common in Montreal. And when the person came in to the interview, he saw the interpreter and just stood with arms crossed, wouldn't sit down for the entire meeting. So eventually we had to ask the interpreter to leave. Then he sat down. So sometimes it's threatening to people, but that's the minority of cases. Mostly it's what you're saying. People are very relieved.
I will tell you why it was threatening without knowing the circumstances, but most likely because it's a local person, small community. I know him.
Could be.
I don't want him to know all the problems I have. Get me a guy from Vancouver. I don't know him.
It's very likely. Very likely.
Thank you.
Those are very important points.
Thank you. You brought up a lot of important points. Some of the family members often wonder, with sectorization, if they would have access to your service, and how would you go about it?
Our service isn't sectored, so sectorized, I should say. So we receive people from everywhere, even sometimes from Ontario or Quebec City, or even.
To go through a local doctor?
There has to be a referring clinician of some kind. Doesn't have to be a doctor. It could be like a psychologist, a social worker, any clinician that we can work with. You know, sometimes we make recommendations where they need a family doctor or even a psychiatrist, so we'll try to work with them to get that. You know, but yeah, we're not sectorized, so we can take referrals from anywhere.
I was wondering if the family can force the psychiatrist who treats our loved ones somehow force them to send the patient to you. So
Force them to send the patient where?
To
our team?
Yeah,
Okay.
your team. Because I asked for my son. You were referring during your speech to the refugees in the, but there are a lot of people like my family that we came here long time ago, but our kids, however, they're raised in a multicultural.
Right.
So what is the sources that we can use? I mean,
that's a very good question. You mean you have a family if you have a family member that really needs psychiatric help and they don't want to go, is that what you mean?
no, he is already there.
He already is going.
But
Oh,
I
okay.
want the reevaluation because always they are telling me that there is this part that we don't know.
I
And
see.
that part that they don't know, it causes a lot of problem because they basically try different medication and you know that the adjustment, all those things, he went through all of them. Now he's not doing well.
Not
Yes,
doing so
he's
well.
calm. Yes, he's not aggressive, but he's not doing well.
Not super well. Well, what
Not
you can
even well.
Yeah.
Let's just forget super well.
what you can do in that case is you can ask the clinician. Is he have a psychiatrist, psychologist? You can ask them. You can tell them about the cultural consultation service, and see if they want to have an opinion from us, and that we would accept their referral. You know, we'd be happy to. I mean, there might be a bit of a wait list. It depends. Right now, it may be in April we're seeing people or something, but it's not super long. So, yeah, we see them. We see them, and we don't follow people. So we would give an opinion, and kind of try to clarify what factors may be at play, and then we go from there. And then maybe the clinician would ask us to look in later if needed, maybe in a year or something. It's possible. So that's how they go a lot. So it could come from a social worker. But if there is a psychiatrist involved, we'd probably ask permission to talk to the psychiatrist, to at least send our recommendations, because, you know, that's an important part of the team. If there's a psychologist, we try to get permission to speak to everybody, you know, family, psychologists, social workers, whoever is important to the patient, if the patient gives us the permission. Yeah, the Antonella, the intake coordinator, she has a list of things that she asks every clinician to give us. So we have to have all kinds of information. Like, for example, what languages do they speak? How well do they speak French and English? Do they need an interpreter? All that kind of stuff. When did they come to Canada? Is there a refugee claim? What's the main issues? So she works with the clinician to get all that stuff. And we need that just to kind of decide how to proceed. What do we need? What kinds of people do we need to bring into the consultation? Do we need a cultural broker? Do Do we need a language interpreter? Do we need how many clinicians? We'd like to have the clinicians come. We almost insist on it now. We're getting more. We have to be more strict because some people send people and then we never hear from them, and they're trying to just sort of, they're trying just to get some help with somebody, but the idea is we don't take over. We have to refer back. So.
I want to know, in your experience, do you think there are some cultures that have a more stigma on mental health than other cultures, or are more open to seeking help?
Mm-hmm. In my experience, all cultures stigmatize mental disorders. I haven't encountered one that doesn't, including our own. Canadian society, Quebec society, is quite punishing to people that have a wide variety of mental health problems. So, yeah, I'd be very hesitant to say there's one that's worse than another. I think it often goes family by family. So some families are really trying to hear and listen. All families are trying to help. I mean, very rarely family members aren't trying to help. It's just sometimes there's strong beliefs maybe in a family, or strong reactions, or maybe difficult experiences as well. Families have lived through, so it might make it more complicated. So yeah, that's my short answer. I think it's unique. There are different ways that stigma plays itself out in different groups and societies. It's an interesting question. Well, one of the things we try to do is we try to destigmatize in all the people that we see. We try to destigmatize the condition. We try to bring out that the person is just that, an individual, and everybody has challenges. No one's free of challenges in life. And then what we try to do is we try to find interventions that will destigmatize or lessen the burden on people. So if somebody wants to volunteer, say, in the Gurdwara, the Sikh temple, and there's an avenue to do that, and that's better for them than going to a work or employment program, maybe, at the hospital, we may say, let's try it, let's see what happens. I mean, maybe that's going to be a way for that person to come out from under this burden of stigma, fit back into their community, and start doing something that they love, So that's how we try to approach it. And as I say, I think every community has problems with stigma. So, on the back.
Hi, we have a question that is slightly different from the theme, but in a way related, because we are private home caregivers of mental health outpatients of several hospitals in Montreal. Mm-hmm. And we have been for the last 4 years trying to find any organization, institution, or service that would help us cope with the service that we're providing. Maybe, just basic orientation, because all of the patients we work with have a medical team with them. Right?
So everyone who lives with you already has a team?
Yes, we don't take people off the streets, but we end up having to spend most of the time, because they are now transitioning from hospitals to hopefully the independent living in the community. And especially considering all the issues of stigma and so, we have a need to get either orientation or any form of information, orientation, training. We don't want to replace the experts in the field, but just for the segment of the work that we do with them, and some of them have been with us for 4 years, we just can't yet find any resources of that nature. Yeah. And we've been asking and asking and asking, and we haven't come up with anything. So we just wanted to know if you can refer us to any such support services in the community, because there are other people who are doing it, because the public residential services are not adequate to accommodate all of the people who need it.
Do you know about AMI Quebec?
Some of our patients
families,
go to
right?
them, they just go to visit, but we are talking about something that's for us
Right.
That will help
You're not
us.
family, really, but in a way you are family, in a way.
Right. So we like supervise them and things like that. But we have absolutely no training. We just got into it from word of mouth. And we don't expect or hope to become experts because they do have medical teams that work with them. But for the part that we do, there's absolutely nothing that we know of.
You're kind of looking for support for group home workers or owners.
Yes, a little understanding, a better understanding of mental health conditions based on the diagnoses, some network support, because there are times when there's an emergency with a particular patient. We can't reach the staff at the hospital because it's a weekend or a long holiday, or whatever the issue, or just to cope or to be able to observe them better when they're in our care.
I think I know what you should do. We have at the hospital, all the hospitals have rounds, okay, where they go rounds, like hospital rounds, where they go over different topics of mental illness or psychiatric problems. And they're open to the public, really. I mean, anybody can go. So we have one tomorrow, for example, on first episode, Psychosis. So at the Jewish General from 1:30 to 3. They're on Thursday afternoons at the Jewish General, but there might be rounds at the Lake Shore. I'm not sure where you live. So I would get a list of call hospitals and ask when their psychiatry rounds are, and start attending. And then you'll start to learn all kinds of stuff, And they sometimes have discussions on group homes, and we had a person come talk to us about Dunham House last month. It's a home in the townships for people struggling with addictions. So it's not all super technical material. Some of it's more about how to help people in very practical ways too. So that's what I would do. I would look for hospital rounds and go and attend them. Thank you.